key clinical points. Postmenopausal osteoporosis. Fragility fractures are very common among postmenopausal women and are associated with increased morbidity, mortality, and healthcare expenditures. Dual energy X-ray absorptiometry, DXA, is recommended in postmenopausal women 65 years of age or older and postmenopausal women younger than 65 years of age who have risk factors. Osteoporosis is diagnosed on the basis of a fragility fracture or a DXA T-score of -2.5 or less. Treatment of postmenopausal osteoporosis is recommended for patients who have any of the following findings: a fragility fracture or fractures, particularly of the hip or spine, regardless of the patient's bone mineral density, a T-score of -2.5 or less at the lumbar spine, total hip or femoral neck, or a high 10-year fracture risk. Hip fracture risk of greater than or equal to 3% or major osteoporotic fracture risk of greater than or equal to 20%, according to the Fracture Risk Assessment Tool, FREX. Evaluation should include risk stratification based on the T-score, presence of fractures, and FREX score, to categorize candidates who meet treatment thresholds as high risk or very high risk. The selection of therapy must include consideration of coexisting conditions and contraindications, but anabolic agents are the preferred first line of treatment in women at very high risk. A 69-year-old woman presents to review the results of her first dual energy X-ray absorptiometry, DXA, scan. Her T-scores are -2.6 at the lumbar spine and -2.3 at the total hip. She fell while walking 18 months ago and fractured her left humerus. Imaging of the spine, performed to investigate 5 centimeters, 2 inches, of height loss and moderate thoracic kyphosis, reveals 2 vertebral fractures. How should this patient be evaluated and treated? Postmenopausal osteoporosis is diagnosed on the basis of the occurrence of a fragility fracture, with no associated trauma or with trauma equivalent to falling from a standing height or less, or bone mineral density at the spine, total hip, or femoral neck that is at least 2.5 standard deviations below the mean of that in a young adult reference population, T-score of -2.5 or less, as measured with the use of DXA. The clinical problem postmenopausal osteoporosis. Cause: estrogen deficiency leads to increased osteoclast activity, causing bone resorption to outpace formation, with rapid bone loss around menopause. Consequences: low bone mineral density, BMD, deteriorated bone microarchitecture, decreased bone strength, and increased fragility fracture risk. Diagnosis: fragility fracture from standing height or less, or DXA T-score less than or equal to -2.5 at spine, total hip, or femoral neck. Prevalence in U.S. 20% of women greater than 50 years and 30% of women greater than or equal to 65 years meet DXA criteria for osteoporosis. More common in white, Asian, and Hispanic women than in non-Hispanic Black women. Another 40% have osteopenia, T-score -1.0 to -2.49. Fracture burden: 50% of postmenopausal women will have fragility fractures, causing pain, disability, and reduced quality of life. Post-hip fracture outcomes: many lose independence, 20% become institutionalized, and 1-year mortality risk doubles. Racial disparities: non-white women with hip fractures have higher 6-month mortality, less independence recovery, and less timely surgery/rehabilitation than white women. Costs: current annual U.S. healthcare cost is $57 billion, projected to exceed $95 billion by 2040. Diagnosis and evaluation: asymptomatic until fracture. Osteoporosis has no symptoms until the first clinical fracture. DXA is gold standard, measures BMD, each 1 SD reduction below T-score 0 doubles/triples fracture risk. Screening recommendations: DXA of spine/hip for all postmenopausal women greater than or equal to 65 years, and for those less than 65 with risk factors. Forearm DXA, useful if spine/hip not evaluable or if hyperparathyroidism present. Fragility fracture equals diagnosis: fractures of spine, hip, forearm, humerus, Pelvis diagnose osteoporosis even if T-score minus 2.5. Imminent risk. A fragility fracture markedly increases the risk of additional fractures soon after. Vertebral fractures, most common, may be painful or asymptomatic, cause height loss, increase mortality. Their presence guides diagnosis and treatment. Vertebral fracture analysis, VFA low radiation spine imaging on densitometer. High sensitivity/specificity for moderate/severe, greater than or equal to 25% compressions. Indicated if height loss greater than 1.5 inches or if management may change. FREX estimates 10-year probability of major osteoporotic or hip fracture using clinical risk factors, plus or minus BMD. Elevated fracture risk without T less than or equal to minus 2.5. Many experts call this osteoporosis. Trabecular bone score, TBS FDA cleared, Medicare covered, indirect measure of spine microarchitecture from DXA, predicts fracture risk independent of BMD. Useful when near treatment threshold, e.g., osteopenia, not for diagnosis alone. Opportunistic CT screening. FDA-approved software can assess volumetric BMD, bone strength, and prevalent fractures from routine CT. Performs at least as well as DXA. HRPQ-CT measures bone microstructure/strength, predicts fracture risk independent of BMD, but not FDA-approved for diagnosis. Other evaluations. Medical history and risk factors. Assess medications, conditions, and other metabolic bone diseases, e.g., osteomalacia. Remediable causes. Address conditions, e.g., celiac disease, and medications, e.g., glucocorticoids, that cause bone loss. Laboratory testing. No consensus on most cost-effective panel. Testing should identify contraindications to specific therapies. Treatment. Fundamental goal. Prevent fractures in high-risk women. Primary prevention before first fracture and secondary prevention before subsequent fracture. Lifestyle modifications. Applicable to all patients. Pharmacologic interventions targeted to women at high fracture risk. Intervention thresholds vary by guideline, but common recommendations include fragility fracture of hip or spine, regardless of BMD. T-score less than or equal to minus 2.5 at lumbar spine, total hip, or femoral neck. High 10-year fracture risk by FREX, e.g., hip fracture risk greater than or equal to 3% or major osteoporotic fracture risk greater than or equal to 20%. Evidence base. Strong RCT support for FDA-approved treatments based on T-scores or fracture criteria, or both. Evidence for treatment based solely on FREX estimated risk is less robust. Risk factors for postmenopausal osteoporosis and fracture. Older age. Low weight. Less than 127 pounds, 58 kilograms. Previous fracture during adulthood, particularly hip, spine, or wrist. Recent fracture indicates a higher risk than. Remote or unclear history. Parental history of hip fracture. Current or past glucocorticoid treatment, greater than 5 milligrams prednisolone. Daily or equivalent for 3 mO or more. Other medications that cause bone loss asterisk. Current smoking. Excess alcohol intake. Causes of secondary osteoporosis. Rheumatoid arthritis. Premature menopause, less than 40 years of age, or hypogonadism. Frequent falls. Lifestyle changes for postmenopausal osteoporosis. General recommendations. Stop smoking, avoid excessive alcohol, increase weight-bearing exercise, and prevent falls. Calcium, 1,000 to 1,200 milligrams daily, preferably from diet. Vitamin D, 400 to 1,000 IU daily. Some experts suggest targeting serum 25-hydroxyvitamin D greater than 20 to 30 nanograms per milliliter, but this is controversial and lacks rigorous data. Fracture reduction debate. Limited evidence shows calcium plus vitamin D significantly reduces hip fractures, but not nonvertebral or vertebral fractures. Rationale for supplementation. Most osteoporosis medication efficacy was studied with calcium plus vitamin D. Some osteoporosis drugs can cause hypocalcemia. Adequate intake is prudent. Risks of calcium supplements. Nephrolithiasis. Possible increased cardiovascular events per some meta-analyses. though those studies were not designed to assess CV outcomes. General principles. Mechanisms. Anti-resorptive therapies, acting by reducing bone resorption, anabolic therapies, stimulating bone formation, or both. Fracture reduction. All pharmacologic approaches reduce vertebral fracture risk, and some reduce the risk of non-vertebral and hip fractures. Risk definitions. High risk. High risk for fracture is typically defined as meeting the minimal intervention thresholds. The examples like T less than or equal to minus 2.5, fragility fracture, or high FREX score. Very high risk is typically defined as having a T-score of less than minus 3.0, a fragility fracture, an AT score of minus 2.5 or less, or multiple vertebral fractures. Most guidelines suggest initial treatment with anabolic agents in women at very high risk, unless contraindicated. Bisphosphonates. First line for high-risk women: efficacy, safety, low cost, convenience, enduring effects after stopping. FDA approved: alendronate, risedronate, ibandronate, oral, zoledronate, 4. All reduce vertebral fractures. All except ibandronate reduce hip/non-vertebral fractures. Zoledronate given within 90 days post-hip fracture and annually for 3 years reduces mortality. Mechanism unclear. Side effects: poor absorption, GI mucosal irritation, oral. Acute phase reactions, zoledronate, managed with hydration/acetaminophen. Long-term, very low risks of osteonecrosis of the jaw, ONJ, and atypical femur fractures, AFF. Denosumab. An alternative option for women at high risk for fracture who have contraindications to bisphosphonates or cannot take them owing to unacceptable adverse effects. Reduces spine, hip, and non-vertebral fractures versus placebo, 3-year RCT. Long-term extension maintains fracture reduction. Greater BMD gains than bisphosphonates, but limited evidence for superior fracture reduction. Rarely associated with ONJ, AFF, and hypocalcemia, risk in advanced CKD or vitamin D deficiency. Major concern: accelerated bone loss and rebound vertebral fractures after discontinuation. Post hoc analysis showed multiple vertebral fractures 3.4% versus 2.2% after placebo. Therefore, denosumab must be continued indefinitely or transition to bisphosphonate. Transition strategies: alendronate weekly starting 6 months after last denosumab dose. Zoledronate at 6 to 7 months after last dose plus or minus repeat 3 to 6 months later. Timely dosing every 6 months critical. Delay greater than 16 weeks, nearly 4 times higher vertebral fracture risk. PTH receptor agonists, teriparatide, abaloparatide. Daily subcutaneous injections for 18 to 24 months reduce vertebral and non-vertebral fractures versus placebo. No proven hip fracture reduction, underpowered. Require follow-on anti-resorptive therapy after completion, otherwise BMD declines within a year. Indications: limited to very high risk or failure/intolerance of other therapies. Abaloparatide may produce greater hip BMD gains than teriparatide. Teriparatide increases spine BMD more than alendronate and reduces vertebral fractures more than risedronate. Osteosarcoma risk. Rodent studies showed increased risk, leading to black box warning and 2-year limit. Recent data show incidence similar to background. FDA removed time limit for some agents, but limited long-term safety data. Avoid in Paget's disease or prior skeletal irradiation. Romosozumab. Monthly subcutaneous injections, newest FDA-approved agent. Phase 2. Increased BMD more than teriparatide. Frame trial. Reduced vertebral and clinical fractures versus placebo at 12 months. Benefit maintained after 1 year of denosumab. Another trial versus alendronate. Both followed by alendronate romosozumab reduced vertebral, non-vertebral, and hip fractures more than alendronate. Black box warning. Higher serious cardiovascular events, 2.5% versus 1.9%. Do not use within 1 year of MI or stroke. Guidelines. Initial therapy only for very high risk, limited to 1 year. Must be followed by bisphosphonate or denosumab. Other anti-resorptive agents. estrogen, and SERMs, only for selected populations due to adverse effects. Calcitonin, weak antiresorptive, rarely used. Combination treatment. Teriparatide plus bisphosphonate, no added BMD benefit versus teriparatide alone. Denosumab plus teriparatide increases hip/spine BMD more than either alone, but not endorsed by guidelines nor routinely covered by insurance. Monitoring. Repeat DXA. Most guidelines recommend repeating DXA 1 to 2 years after initiating or changing therapy. Recommendations diverge beyond that. Non-response, defined as a decrease in BMD greater than the least significant change, occurs in greater than or equal to 10% of patients. No zero risk. No treatment reduces fracture risk to zero. Indications for reevaluation. Decreasing BMD or occurrence of multiple fractures should prompt evaluation and consideration of alternative therapy. Bone turnover markers. Some clinicians measure them 3 to 6 months after starting antiresorptive therapy to assess adherence and response, but this approach is not routinely recommended, despite association between declines in markers and fracture risk reduction in large trials. Bisphosphonate duration and drug holidays. Unclear optimal duration of bisphosphonate therapy. Extended trials, alendronate 10 years, zoledronate 6 years discontinuing after 5 years, oral, or 3 years, 4, led to lower BMD, still above pretreatment, and more vertebral fractures, but not nonvertebral, versus continuing. Atypical femur fracture, AFF, risk decreases after stopping, from 4.50 per 10,000 person years, current users, 1.81, 3 to 15 MO after stop, 0.5, greater than 15 MO after stop. Drug holiday recommendation. For women not at high risk, consider holiday after 5 years oral or 3 years for bisphosphonate. For high-risk women, treatment up to 10 years, oral, or 6 years, 4, is suggested with periodic reevaluation. Resuming after holiday. Consider incident fractures, decreasing BMD, bone turnover markers returning to pretreatment values, and return to intervention thresholds. Denosumab duration. Appropriate duration unclear. Endocrine Society. Reassess fracture risk after 5 to 10 years. Continue or switch if still high risk. Risk of multiple vertebral fractures after discontinuation may increase with longer denosumab duration. Sequential pharmacologic treatment. Limited data to guide sequencing. Antiresorptives blunt/delay BMD gains from anabolic agents. Switching from bisphosphonates to romosozumab greater BMD increases than teriparatide, but fracture data lacking. Avoid switching from denosumab to teriparatide causes bone loss. Treat to target approach. Some experts recommend selecting/modifying therapy to achieve an acceptable fracture risk level, e.g., T-score -2.0. Appropriate thresholds are unclear, more data needed. Conclusions and recommendations. Typical presentation. Initial humerus fracture was not recognized as indicating osteoporosis. Diagnosis was later made by T-score of -2.6 and prevalent vertebral fractures. Very high risk. Multiple fragility fractures indicate a very high risk of additional fractures. Author's preferred approach. First line, anabolic agents, PTH receptor agonist or romosozumab, followed by a bisphosphonate or denosumab. If anabolic therapy is declined, prefer denosumab over bisphosphonates due to severe osteoporosis and denosumab's greater effects on BMD. Monitoring. Despite debated utility of repeat DXA, they would reevaluate clinically and repeat DXA 1 to 2 years after initiating therapy.